Dear colleagues, ladies and gentlemen, it's a pleasure for me to welcome you to this educational medical activity, Challenges in Diagnosis and Management of Resistant Pathogens Causing Urinary Tract Infections and Recurrent Urinary Tract Infections. So this medical education activity also takes place on the time of the Antibiotic Awareness Week, which is always in November. Given the fact that urinary tract infections are amongst the most frequent bacterial infections that prompt antibiotic prescriptions, therefore antimicrobial resistance is an important issue in this regard. This is a GSK organized and funded medical education activity. Not all the medicines and/or indications presented in this webinar may be approved for use in all countries. Please contact your GSK medical advisor if you have any questions regarding these issues. This medical education activity is intended for healthcare professionals only. These slides were not developed by GSK, and the external expert is responsible for any necessary third-party consents. Slide may not be reused without obtaining copyright permissions. The content is protected by copyright and cannot be reproduced by photo recording or screenshots, nor disclosed or transmitted to any third party by any means without the written authorization of GSK. So I would like to introduce the faculty. The first speaker will be Dr. Deborah Frommer. Dr. Deborah Frommer is Associate Professor of Urology and Chief of Female Pelvic Medicine and Reconstructive Urology at Hackensack Meridian Health School of Medicine in Hackensack, New Jersey. Her area of expertise includes recurrent and complicated urinary tract infections with a research interests in antibiotic stewardship and multi-drug resistant organisms causing urinary tract infection. She will center her presentation around a case presentation of a patient with a sporadic urinary tract infection. The second speaker is Professor Vikram Khullar. He is a subspecialist in urogynecology, clinical lead of urogynecology at St. Mary's Hospital, and professor of practice urogynecology of the Imperial College London, United Kingdom. Dr. Khullar's interests include quality of life issues, surgical treatment of urinary incontinence and vaginal prolapse, and topics related to urodynamics with an especial interest in symptomatology. Dr. Khullar is a member of several organizations, including the International Continence Society, the International Urogynecology Association, and the British Society of Urogynecology. Vikram, please, your presentation.
Thank you very much. I'd like to talk about an acute uncomplicated urinary tract infection with a background history of recurrent UTI. These are my disclosures. So patient 2 is a 60-year-old postmenopausal woman. She's presenting with lower urinary tract infection symptoms. She has dysuria, lower abdominal pain, cloudy urine. She also has type 2 diabetes, which up till now has been very well controlled on oral medication. And when she's examined, she has vaginal atrophy and discomfort. She's also had 4 urinary tract infections in the last year, which puts her in the category of recurrent urinary tract infections, which is 3 or more. And previously, with these infections, she's noted that a 5-day course of nitrofurantoin produces complete resolution. However, worryingly, the last 2 were confirmed on urine culture as E. coli, and they were resistant to nitrofurantoin, and therefore she required different antibiotic therapy.
So I think in the context of the symptoms, and the patient probably knows very well the symptoms she has for the urinary tract infection, is there any additional diagnosis you would give her, and any additional investigations you would do?
Well, at the point of seeing her, she could have urinalysis. We could see if there are leukocytes or blood in her urine. We should, of course, check her temperature, because we don't want a patient who's pyrexial. And I would, of course, want to make sure that she did not have any kidney tenderness, that there's no evidence of pyelonephritis. The other issues in relation to her history are factors which may lead to these infections. Has she constipation? We know that she's got vaginal atrophy. Was she on any hormone replacement, or has she never been on hormone replacement? Does she have a breast cancer risk? So that would influence whether or not she was a candidate for hormone replacement. So there are other factors relating to this patient's life in general, and also the crucial thing about fluid intake.
And what about the diabetes? You mentioned it's well controlled. Would it make a difference if she has an uncontrolled diabetes, or would you somehow include blood sugar measurement in that scenario already?
Well, we will come to this, but you're absolutely right. When a patient says they're well controlled, and if it's based on oral medication, often the patient may occasionally have an HbA1c, but there will not be checks for postprandial glucose levels. So these patients may have very high levels of glucose which are never checked, and therefore whether the patient truly has good control, we don't know. And at the time of coming in with an infection, probably their control will not be good. Certainly in terms of diagnostic evaluation, I would want to order a urine culture, and as she has symptoms, and these are causing her many problems, and we must take into account this history, because sometimes these patients will present with a lower count, so less than 100,000 culture forming units per mil, or the patient may present with a mixed growth, and this age group, this postmenopausal age group, will often have mixed growths, including streptococci, staphylococci, proteus, citrobacter. Another issue is, does the patient empty their bladder properly? So we may wish to assess the flow rate, see if there's a post-void residual, particularly if the patient has prolapse, which could increase the post-void residual.
Do you have any cutoff volume for the residual? Would it be above 100 mils, 150 mils, below 100 mils? Is there anything you would consider significant?
There is one paper which looked at recurrent urinary tract infections and post-void residual, and they determined that there was a cutoff of 150 mils. Having said that, I certainly notice that patients who have residuals more than 100 milliliters, when we treat these patients, we will find that antibiotics will be less effective, and they're much more likely to come back with recurrent infections. So the literature says 150. My personal viewpoint is 100.
Okay.
And obviously, if the patient has hematuria, microscopic hematuria, it is important to image the upper tracts to check either with ultrasound, or certainly if there is obvious hematuria, a CT urogram.
But if this is during the infection, would you also image with a CT urogram?
It would be really if after the infection had been treated, if the patient had hematuria at that stage. I agree. I would not base it on somebody having an infection and having blood in the urine. And
especially in women, we have significantly higher advanced stages of bladder cancer compared to males, because probably hematuria is often overlooked or not considered to be something significant.
Yes.
Deborah, is that also, are you doing this similarly in your practice? especially if the patient comes back with hematuria, performing cystoscopy?
Absolutely. So if the hematuria continues to be present despite negative cultures, they get a full microhematuria workup. Some of the US data has shown a significant delay in diagnosis for bladder cancer in women. And I think that this is because many women who present with symptoms of CIS or bladder cancer, if they have bladder pain and hematuria, they're automatically written off as having UTI, when in fact they may have low-grade bladder cancer that is then left to progress. So I think that that's, again, important when we see our patients that have these symptoms and they have hematuria. It's important not to brush off the hematuria. So even if they have bacteria, you treat the bacteria, you clear it, they still have hematuria or they still have symptoms, a cystoscopy could be critical.
Agreed.
And I think with this, we certainly with tapes, and if the patient has persistent pain after having an infection, we must wonder whether there is a foreign body. So looking inside the bladder would be an ideal way in a patient who's had either a vaginal mesh or a suburethral tape. Do they perhaps have some kind of erosion of the mesh? And lastly, because this lady has diabetes, checking her HbA1c would be important. So what are the factors particularly relating to this lady? And this is looking at risk of recurrence in women over the age of 55, and factors such as diabetes, vaginal atrophy, also patients having urinary incontinence. They may restrict their fluid because of the problem of frequency and incontinence, and this can lead to infection. If patients have vaginal wall prolapse, either anterior or posterior vaginal wall prolapse, they can impact on the ability of the bladder to empty. And if these patients, we've spoken about increased post-void residual, that can play a role. And lastly, patients who are catheterized, patients who have indwelling catheters or are intimately self-catheterizing, there could be the risk of urinary tract infection as a result. So what about diabetes in this case? Well, the patient having diabetes, the overall risk of recurrence is an odds ratio of double. So double the chance of getting a urinary tract infection. If the patient is on oral diabetic medication, the chance of recurrent urinary tract infections is about 2.1. If they're on insulin, the odds ratio goes up to 3. And there also seems to be an impact of if the patient has had diabetes for more than 5 years. And there certainly is evidence that patients who have diabetes, particularly insulin-dependent diabetics, have abnormal bladder function. It basically impacts on the sensory and motor function of the bladder, and they can then end up with an even higher risk of recurrent urinary tract infection. So, okay, we've got these risk factors for recurrent UTIs, and I thought it was important to share this model because it gives an idea about the impact of different factors leading to recurrence of urinary tract infections. So this is a normogram using many different studies and papers, and it was published this year, and we can see at the top of the normogram a point score, and this is the number of sexual partners, either 1, 2, or more than 3, and then you can see the number of points from each. In terms of bowel function, if we have normal, diarrhea, so having diarrhea will also increase the risk of urinary tract infection, and constipation gives about 50 points. The type of pathogen also impacts on the risk of recurrent urinary tract infections. If it's gram-negative, there's a higher risk than gram-positive. Patients who are premenopausal versus postmenopausal, there is an impact, but you can see it's not as great as constipation. And having recurrent UTIs, having more than 3, in a way, this is a self-selected group. So the patients who have more recurrent UTIs are the ones who have more risk of further recurrent UTIs. And it's important here to look at the impact of antibiotic therapy, that by giving antibiotics, the risk of recurrent UTIs is greatly increased, as much as constipation. And when we add all these points up, you can then work out the probability of recurrence in a 12-month period. But this just gives an idea of all the different factors and how they can impact on a patient in terms of developing recurrent UTIs.
Now, Professor Khullar, you showed now this patient has frequent urinary tract infections. So it's not a sporadic UTI. So she has more than 3 in a year, maybe even much more than that. Is this having a different impact on the patient than if she would have sporadic UTI?
I think it becomes a constant fear. It will impact on the patient's life in terms of their personal relationships. We certainly know that sexual intercourse increases the risk of recurrent UTIs by 10 times. It's the biggest factor. And that can then lead to problems in the patient's relationship by altering their fluid intake, having urinary symptoms. We know this also has an impact in terms of how a person works, where they work, when they decide to have retirement or take early retirement due to their urinary tract infections or symptoms. So all of these factors are very important in altering the person's life. And this is looking at the potential impact of recurrent UTIs on the patient. And this is some of Deborah's data, looking at reduced quality of life. And obviously, in this, we've got a 6-month observational study. And using the HAD scale, which is the Hospital Anxiety Depression Rating Scale, we can see that around 62% of patients had some degree of depression, even though they may not have had a current UTI. So the whole idea of the recurrent urinary tract infection has an impact on the person's life, even when they do not have an infection. And around 30% had a high anxious depressive state because they're worried about an infection coming back. Other papers have shown increased sleep disruption, persistent fatigue, this important impact on intimate relationships, and the consequences of taking time off from work and the ultimate financial impact to the patient. So we must not lose sight of these important features.
So can we quickly prompt here? So in this patient with recurrent UTI, probably a lot of antibiotics in the past. Is that influencing your prescribing with respect to the risk of antimicrobial resistance? Deborah, maybe could you allude to that in contrast to the patient you have described in your presentation?
Yeah, so this patient I would be much more cautious with. Obviously, a more complicated patient, a greater risk of having antimicrobial resistance, and someone that is more at risk of having a complicated UTI and having upper tract issues.
Vikram, is there a risk of an increased antimicrobial resistance in those patients that have recurrent UTI?
Absolutely. They have a much higher rate of antimicrobial resistance. The organisms have come into contact with different antibiotics, and the use of antibiotics increases that risk. But also, these antibiotics seem to have failed. So the patient has come back with more infections. And often there may well be intrinsic problems, such as this patient having diabetes, which mean that it's more difficult to clear the infection. And therefore, the organism has more of a chance of becoming resistant. So, this patient, absolutely, we have more risks of antimicrobial resistance. And I think we should be thinking about primarily behavioral changes, things that we can do to prevent the recurrent urinary tract infections, such as, does the patient have constipation? Can we, and if the patient has a problem with their bowels, can we make the bowels work better? Even if the patient has diarrhea, should they be treated from a intestinal point of view. So there are these other factors which we need to involve, or using other options which are not antibiotic, such as estrogen vaginally. So what about this link between recurrent UTIs and antimicrobial resistance? Here we can look at some data from Dr. Frimmer's practice, and there were 334 patients identified with UTIs, and 704 had positive cultures, and 46% were classified as recurrent UTIs. So it's quite important. This is a large number of the overall group have recurrent urinary tract infections. And importantly, that even though this is just looking at the E. coli, that they were resistant to 3 or more oral antibiotics. And this is compared with 20% of cultures from those patients who've just had a single urinary tract infection. And importantly, the other organisms, such as Klebsiella, tend to have much more innate resistance. So they can be a very important group and very difficult to treat. Certainly in this group, resistance was to fluoroquinolones and to trimethoprim sulfamoxazole was more common among the E. coli group, which were obtained from those patients with recurrent UTIs. And that's around 40% compared with 28%. So what are the key points to consider? We want to check the local uropathogen resistance patterns, as they can vary between the regions and countries. So the fluoroquinolone resistance in Southern Europe, penicillin resistance in the UK, or looking at, for example, this is the Infectious Disease Society of America. The guidelines recommend not using trimethoprim and sulfamoxazole empirically as where the local resistance is greater than 20%. So it is important for each practitioner to know their local resistance patterns, because there is no point giving a prescription of medication where it will not work. And this then leads to using antibiotics with reported lower levels of resistance. It is important to reduce the use of broad-spectrum antibiotics, as they not only impact on the patient's bladder, but they alter the gut flora. And certainly in my practice, considering the 5 to 7 day course of antibiotic treatment rather than 3 days, as there is now data to show that very short course of antibiotics lead to a recurrence of infection and resistance. So from my perspective, what do I find the management for this patient? Certainly counseling. Is the patient drinking an adequate amount of fluid? Do they have constipation? Should we be giving them some kind of medication to help their bowels work normally? Do they have prolapse? Should the prolapse be treated? And that could even be pelvic floor exercises, ring pessaries, or surgery. If it's related to intercourse, is the patient passing urine after sexual intercourse? Are they taking D-mannose or cranberry? Have they tried non-antimicrobial measures, such as vaginal probiotics, or using estrogens vaginally? And then lastly, in some patients, we cannot control their recurrent UTIs just based on the counseling, behavioral modification, and non-antimicrobial measures. And sometimes we will end up using antimicrobial prophylaxis. But we really want to avoid the broad spectrum antibiotics, because if resistance occurs, it may become more difficult to treat this patient. And certainly if the patient has significant post-void residual, about the patient learning, particularly if it's over 150 milliliters, the patient learning clean intermittent self-catheterization. So what sort of evidence is there for these different approaches? In terms of non-antimicrobial prophylaxis, vaginal estrogens have been found in placebo-controlled studies to reduce by half the rate of urinary tract infection. There are vaccines, either which seem to work by altering T-cell activity, which can be taken orally or sublingually, which have been found. The treatments tend to last for about 3 months, and then when at follow-up, they reduce the rate of recurrent urinary tract infection by 90%. Probiotics, oral probiotics have not been shown to work. Intravaginal probiotics, it's very specific. L. rhamnosus and Lactobacillus reuteri and Lactobacillus crispatus have been shown in placebo-controlled studies to prevent recurrent urinary tract infections. There's unfortunately no evidence for the benefit of cranberry juice, but this may just be the size of the studies. There are data to show that D-mannose, 1 gram taken twice a day, does prevent recurrent urinary tract infections. And there are 2 small randomized studies which show that bladder installations with hyaluronic acid and chondroitin sulfate can stop recurrent urinary tract infections. But this really would be a last resort. So what about estrogens? Importantly, it is vaginal estrogens. They alter the microbiome in the vagina. They decrease the vaginal pH, making it more hostile for pathogens. And this is done by increasing glycogen, increasing the lactobacillus concentration, and this then increases the antibacterial peptides. There is also data which is published this year to show that increasing the lactobacilli in the vagina lead to lactobacilli in the bladder, which then prevent pathological organisms. But the studies all show that these estrogens have to be used for a minimum of 3 months to show an effect. And this is one of the randomized studies looking at Lactobacillus crispatus given vaginally to prevent recurrent urinary tract infections. And the reduction in rate was about half. So it didn't work in all patients, but they did find a reduction in recurrent urinary tract infection.
So Vikram, you would first counsel the patient, and what specific strategies would you tell the patient? What about increased fluid intake? Is there a room for these very simple strategies, very simple methods?
Yes, there certainly are. I think one of the key things is that patients sometimes misunderstand and think that the more they drink, the better. And certainly from my personal opinion, I have found that patients who do not drink consistently through the day can have episodes of dehydration because they drink at the beginning of the day and the end of the day, but in the middle they don't drink, and that's obviously of no value. Or patients may overdrink, and if they drink over 2.5 liters, we have looked at specific gravity of the urine, and they can develop very concentrated urine first thing in the morning when they wake up, as they are relatively fluid depleted due to the excessive drinking during the day. So it's a matter of drinking just the right amount, drinking fluid throughout the day, which is as important as the amount that they drink, and also making sure that the patient, from a dietary point of view, is looking after their bowels, that they do not suffer from constipation, and that if they do want to think about things such as estrogens vaginally, that the patient should be given the opportunity to use them.
Deborah, which of these strategies that Vikram has alluded to is your favorite strategy, or isn't there one single strategy in fitting all the patients? rather than different strategies in an individual and personalized manner?
I wish it was one strategy. It would be a lot quicker conversation with the patients. I have a printout with every one of these strategies that was just presented. And when the patient comes in, I go over every one of them and we go checkbox, checkbox, checkbox with every single one of them. And if I had to pick one that I thought was probably the most important, if I was on a deserted island, it would be the vaginal estrogen.
Now, we have this patient with the acute problem, with the acute symptoms. Now, would you rather discuss with this patient already preventive strategy, or would you do that time by time, first treat the acute episode and then counsel the patient on a follow-up visit? And if yes, what time schedule would you use for following this patient?
I certainly would want to know after treatment that the patient that their symptoms had improved. The other question is that if the patient is still symptomatic, and let us say that this patient had a mixed growth, so we did not know specifically which organism, and they had a mixed growth on 2 occasions, then we sometimes find on follow-up that the patient actually has a specific organism. So we certainly find that recurrent UTIs are at a higher risk in the first 3 months. And certainly if the patient's symptomatic, that would drive the patient in terms of follow-up. And also we would want to follow up the patient if there were issues relating to incomplete bladder emptying, if we needed to assess these, or looking at the results of further investigations. So the more complicated the patient, the more likely they are to follow up. But certainly if the patient had hematuria, I would want to know that the blood in the urine had resolved.